Let me introduce our dear Dr. Raman Verma. Raman and I go more than a decade ago. The year that I joined the Ottawa Hospital as a staff radiologist, that was in 2008, Raman Verma joined as a first year resident. Kind, soft spoken, very likable person from day one. And over the last decade, the way he has evolved as a competent and very good breast radiologist, not just in Canada, but globally, is something to look forward to. He is a staff radiologist and assistant professor with the Department of Medical Imaging at the Ottawa Hospital, University of Ottawa. He has done a breast and women's imaging fellowship from Northwestern University in Chicago. He's the program director for the radiology residency program for the University of Ottawa. And he's also the member of undergraduate medical education. So completely involved in academic activities. He also is one of the course directors for the core residency program teaching, which is the CME courses that are conducted by the University of Ottawa Radiology Review course. So I welcome Raman to teach us how to evaluate nipple discharge, a topic which has a lot of gray zones currently. So over to you, Raman.
Great. Thank you very much, Dr. Patkar, and thank you, Dr. Ladd, for that introduction. I had the pleasure of meeting Dr. Ladd almost a decade ago, like she said, and lasting memories since then. A mentor. I think she's unaware of probably the impact she's had on my career. And so I want to thank her and the organization for inviting me to present to you on nipple discharge. Before we get started, I did want to just mention that, what's going on in India right now is certainly it's in all of our thoughts and prayers, and we're with you while you go through these. And I know, as Dr. Patkar said, you don't want to hear it, but these are unprecedented times, and they really are. So please accept our sincere thoughts and prayers. So I'm a breast radiologist at the Ottawa Hospital, and we'll be speaking to you today about how to evaluate nipple discharge. Some of the learning objectives today: review an algorithmic approach to nipple discharge, describe a multimodality imaging features related to nipple discharge, and then review some of the most recent literature on appropriate management techniques. So nipple discharge is the third most common complaint after breast pain and a mass for diagnostic assessment. More than 80% of women will experience at least one episode of nipple discharge, and the prevalence of symptomatic discharge is increasing in breast clinics, reported to be about 5 to 7.5%. Most often, we want to try to categorize these as either physiologic discharge or pathologic nipple discharge. So physiologic being more bilateral, typically white or greenish, and involving multiple ducts. The causes of that is usually endocrine or medication related. When you compare that to pathologic nipple discharge, these are usually patients who have spontaneous, unilateral, clear or bloody nipple discharge, and usually comes from a single duct. The causes can be for a variety of reasons and often related to either papillomas, ductictasia, or underlying carcinoma. So we'll start off with a case. So if the audience response system is available, we'll use it. If not, we'll just still work through it. But so basically, a 55-year-old female presents with clear, spontaneous, and non-spontaneous right nipple discharge. What is your initial evaluation? Okay, great. So 75% of you said A, and that would be the correct answer. And so when we go through this, I'm going to be referring a lot to the ACR appropriateness criteria for evaluation of nipple discharge. And so when you look at the ACR, the American College of Radiology appropriateness criteria, they classify nipple discharge into physiologic and pathologic discharge, as I had mentioned. So when you have a patient who has physiologic discharge, there's no real indication for imaging, and so they classify that as basically routine imaging or routine screening, and no further diagnostic assessment is required. When you have a patient with pathologic discharge, it's more subdivided in terms of how old the patient is. So if the patient is less than 30, often we'll start with an ultrasound first and then add on a mammogram as needed. For ages between the ages of 30 and 39, we'll start with a mammogram or ultrasound, depending on the institutional preference. And then for patients who are 40 and older, usually we'll start with a mammogram and then add on an ultrasound for further assessment. If all of these are normal and the patient has pathologic discharge, the recommendation should be to proceed on with MRI or surgical referral if MRI is not available for definitive management. If the workup is abnormal, then certainly biopsying the abnormality with either mammogram or ultrasound is the appropriate step. And then to close the loop, if the symptoms are resolved and the lesion is concordant, then the patient can go back to routine screening. However, an important caveat to always keep in mind is that if the symptoms persist or if the lesion is discordant, then definitely coming back to and reassessing the patient with either MRI or surgical referral should be a strong consideration. So in this patient that we had presented, this patient presented with pathologic discharge. She was over the age of 40, so the next best step would be mammogram and ultrasound. Here's another example of a patient who underwent mammogram. Here you can see a circumscribed dense mass in the retroareolar region, slightly outer aspect of the right breast. And when we did an ultrasound, you can see a complex solid and cystic mass in the retroareolar region with associated vascularity of the solid component. And so this was a biopsied under a 14 gauge biopsy, and this was a papillary carcinoma. This is another patient we actually had recently. So these are tomosynthesis synthetic views of the breast bilaterally. The patient presented for right-sided nipple discharge. And you can see that the underlying breast tissue is extremely dense, which can limit assessment. Oftentimes it's been stated that, calcifications pop out quite a bit on tomosynthesis. This was a little bit of a red herring in our practice. You can see here that even when we blow up these images a little bit more, you can see there are some amorphous calcifications in a segmental distribution in the lower inner aspect of the right breast, but they don't pop out as much as we would normally expect. So certainly you have to have a keen eye, and you have to ensure that you're aware of what may be the pathologic process. So for a patient with nipple discharge, calcifications are certainly something to look out for. This was a patient with segmental amorphous and pleomorphic calcifications who underwent subsequent biopsy yielding high-grade DCIS with comedo-necrosis. And you can see on the MRI, there's extensive segmental non-mass enhancement in the corresponding area on the MRI. And we did a second look ultrasound and found some ectatic ducts and then biopsied those with vacuum assistance. It's important to know that a fair portion of patients will present with nipple discharge with DCIS only, and in situ and invasive malignancy accounts for anywhere between 5 and 20% of nipple discharge. What about the role of cytology, which was one of the options on the MCQ question? So there's been many studies done throughout the years, and the general consensus has been that it's not really indicated. And the ACR also doesn't really include it in its workup algorithm. Some of the studies that have been done, summarize that it confuses the workup, may inadvertently delay the outcome, adversely affect patient care, and it really is of no significant value. So it's not something that we really do in our routine practice, and it hasn't really been advocated by the ACR. In terms of initial diagnostic workup, mammogram is usually the standard initial step. It helps to assess the breast globally, and you want to assess for the common causes that we can see, so intraductal papilloma, DCIS, or invasive carcinoma. Ultrasound helps to evaluate the retroareolar region of the symptomatic breast, and it's really important to include because we know that mammogram can be challenging to include properly, to include the retroareolar region properly because of compression issues usually. And so an ultrasound of that region is appropriate. The one thing to always keep in mind is that inherent artifacts in this region can certainly limit assessment. So we want to look at ways to which we can improve ultrasound visualization, and many techniques have been described. There's the two-hand technique where you apply compression with the opposite hand to kind of bring the nipple forward and pull it up, and so that you can use your probe on a obliquely to assess the retroareolar ducts. There's the peripheral compression, where you apply pressure distally and then at the nipple, so kind of toggling back and forth to ensure that there's complete effacement of any potential air gaps. And with that, you want to use an adequate amount of gel. Basically, anytime I'm evaluating the retroareolar region, I will ensure that the patient has a significant amount of gel in that area. And you know, if you can use a standoff pad, but it helps to bring lesions within the focal zone and limit the near field artifacts. Finally, there's the rolled nipple technique, which assists in flattening the area requiring visualization. So there are definitely a lot of possibilities in terms of how to improve it. And I would encourage you, when you're assessing your patients for nipple discharge, to try to utilize some of these techniques to really improve visualization. Okay, so we'll move on to our next polling question. We've kind of referred to this, but what is the most common cause of nipple discharge in a perimenopausal patient? So A, DCIS, B, invasive ductal carcinoma, C, intraductal papilloma, or D, ductal ectasia. Okay, so we have the audience response system, and we'll wait for some answers. Okay, so the D was 62%, and which is ductal ectasia, and a close second was C. So intraductal papilloma is the most common cause of a nipple discharge in a perimenopausal patient, but we'll go through some of the different other causes as well. So here in the retroareolar region, we have 2 ultrasound images demonstrating an intraductal mass with questionable vascularity, and there's associated ductal ectasia. And so we biopsied this using vacuum assistance, and this was a benign intraductal papilloma. Intraductal papillomas are benign neoplasms with proliferation of epithelial and myoepithelial cells. They're usually periareolar around the nipple region and are often accounting for the nipple discharge. And when they're appropriately biopsied or sampled, they can usually, the nipple discharge will usually stop. It can be difficult to differentiate from internal debris or duct ectasia. It is the most common cause, with some series reporting up to 60% of patients for it representing the cause of nipple discharge. Management of benign papillomas without atypia remains variable. Some studies with large sample sizes have quoted upgrade rates ranging from 0 to 12%. You know, now things are changing a little bit in terms of how to manage these. Imaging surveillance versus surgical excision are the main common options. And we are seeing more of a trend towards conservative management. That being said, any patient who presents with atypia, it's fairly widely accepted that those should undergo excision due to high upgrade rates, up to almost 20 to 30%. For incidental papillomas, these are ones where you're biopsying a lesion and the pathologist indicates that there's a presence of an incidental papillary lesion. This is somewhat a little bit more controversial, and they have lower upgrade rates, but observation is becoming quite common in this scenario. And then finally, those patients who are symptomatic, we tend to refer our patients to breast surgery for appropriate management. Some of the breast surgeons will advocate for percutaneous excision. Some will, the majority will usually undergo imaging surveillance, and some will undergo surgical excision depending on patient factors and other risk status. So variable management, certainly. This is a patient who had a known contralateral malignancy. Here we can see a 1.5 centimeter complex solid and cystic mass with associated vascularity. This was biopsied and it was a sclerosing intraductal papilloma with questionable atypia. And so she underwent excision, and there was no upgrade at the time of excision. This is a companion case demonstrating similar ultrasound features. So again, it's very hard to differentiate the two. This was an intracystic appearing mass, 13 millimeters. This was biopsied and was just simply an ectatic duct with debris, no papilloma, and no high-risk features. Recently, actually in just May of this year, just in this month of this year, There was a large study published in AJNR, including 612 benign papillomas, and they demonstrated an upgrade rate of just over 2%. And when they looked at some of their subgroups, there was a 0% upgrade rate among lesions that underwent imaging surveillance. So based on that, they recommended selective surgical excision for those patients who have radiology pathology discordance, age greater than 60 years, symptoms of a palpable mass or nipple discharge, a lesion size greater than 10 millimeters, or the presence of 4 or more metachronous or concurrent peripheral papillomas. Our local practice with our surgeon tends to be more of an imaging surveillance, as I mentioned. And so those patients who have no atypia, and for those lesions that are less than 10 millimeters, they will usually be surveilled. For patients who have any atypia or a size greater than 10 millimeters, those patients will usually undergo excision. Ductictasia is a benign condition in which ducts dilate, usually over 2 millimeters, and thicken. These patients are often asymptomatic, but upwards of 35% can be symptomatic. On mammogram, usually you see tubular branching mass-like structures in the retroareolar region. And on ultrasound, you'll see some dilated ducts with fluid and or debris and or masses. So it can sometimes be challenging to differentiate within true pathologic intraductal mass. On MRI, you'll often see branching T2 hyperintense areas with associated T1 hyperintensity, which can be seen in patients who have hemorrhagic or proteinaceous material. This is a patient who is still, sticks in a lot of our minds at our breast health center. This is a patient who had nipple discharge, and on diagnostic mammography, all we saw was this small grouping of predominantly somewhat dystrophic, but some pleomorphic calcifications in a linear and somewhat branching configuration. So certainly suspicious, certainly warrants biopsy. And the patient underwent stereotactic biopsy, and this revealed high-grade DCIS with comedonecrosis. But you always want to have a high level of suspicion for pathologically suspicious nipple discharge. And in this patient who you can kind of see that the breast tissue density is quite dense, we unfortunately just uncovered the tip of the iceberg. And so when we recommended an MRI for further assessment, you can see that this patient has extensive diffuse non-mass enhancement throughout the entire left breast. This very typical clustered ring appearance, which is very high specificity for DCIS. And so she underwent mastectomy, and they uncovered innumerable foci of microinvasive disease. Another similar patient here, diffuse non-mass enhancement in a segmental pattern. Again, high-grade DCIS with invasive ductal carcinoma. This patient had a negative mammogram and ultrasound presenting for nipple discharge. Move on to our next polling question. So a 40-year-old female presents with bloody unilateral nipple discharge. Mammogram and ultrasound was benign. What is the next best step? So the options are surgical referral, ductography, MRI ductography, or contrast-enhanced MRI. Great. So the majority of you, almost 70%, commented that the D MRI gadolinium enhanced is the appropriate step, and that would be the correct option. A would also be reasonable, especially if you don't have access to MRI. And so certainly many of our community institutions will also recommend surgical referral for these patients for possibility of consideration for central duct excision. But D is the ideal step currently. So when you look at our ACR flowchart here, so this patient presents with pathologic discharge. She's over the age of 40. You can see that the MRI, the mammogram and ultrasound was normal. And so what do you do next? You go on to MRI and or surgical referral. So this is a companion case here in a patient who had similar kind of negative mammogram and ultrasound. You can see ductictasia with diffuse associated linear non-mass enhancement extending to and into the nipple. We did a second look ultrasound, found just basically dilated ducts and some debris. and we did a vacuum assisted 10 gauge biopsy, and this came back as benign hyperplasia, fibrocystic change, and her nipple discharge resolved post vacuum assisted biopsy, and nothing more was required. So breast MRI is certainly becoming the established next step in patients with pathologic nipple discharge, and negative conventional imaging has a high detection rate for invasive breast cancer. And we know the sensitivity of detection of underlying causes of pathologic nipple discharge is also very high with breast MRI. And in 2017, there was a recent study published which kind of concluded that negative MRI with a risk of malignancy showing less than 4% and surveillance rather than surgical duct excision may be reasonable. We did a similar study, which is non-published right now, but will be published soon at our institution. And those we evaluated almost 400 patients, and we had similar risk of malignancy in our patient cohort. So it is a very reasonable test to follow. This is a patient who's 48 years old, presenting with right nipple discharge, very dense breasts, and mammographically you don't really see anything significant here. Here, the patient underwent ultrasound in the retroareolar region, and we see a focally ectatic duct with some intraluminal echogenic material that underwent biopsy, and we came back with benign hyperplasia and fibrocystic change. So the question is, and this is not a polling question, but the question is, what's your next step? Do you do routine screening? Do you follow up with a mammogram or ultrasound? Do you do a breast MRI, or do you correlate with symptoms? And the reason for bringing this forward is that you want to ensure that the patient's symptoms resolve. So you want to make sure that the RAD path and clinical correlation is appropriate. In this patient who the symptoms persisted, we suggested to undergo breast MRI. And you can see here that there's non-mass enhancement in the retroareolar region. This was biopsied with MRI yielding DCIS intermediate grade. And then you can also see that there was a spiculated mass in the upper aspect of the right breast. We did a second look ultrasound, and that was biopsied as an invasive ductal carcinoma. So the key point here is to have a low threshold for additional imaging if the symptoms persist. And so just going back to the ACR criteria here, this is where I want to point out a slight variation in what I feel is an important scenario. So if the mammogram is abnormal and you biopsy it, you really want to assess for concordance and the clinical symptoms. And if they persist, then have a low threshold for recommending MRI or surgical referral for clinical management. Ductography is basically not routinely performed anymore. Actually, I could probably count on one hand the number of ductograms I've performed. One of them was with Dr. Ladd when I was a resident, and I think I've done 3 more after that. And so we do not routinely do these. They are still, tested on our national examination for radiology residents, so we still talk about it. But the triad for success, you need to have an active discharging duct. You need to be able to cannulate the duct, and you need to be able to demonstrate an abnormality for it to be effective. The sensitivity and specificity is certainly very low. And so when you look at some sort of examples that we'll get to soon, I've described a technique here that, you want to use a 27 gauge or 30 gauge blunt tipped cannula. You want to cannulate the duct and then be prepared to biopsy it, either using stereotactic or ultrasound guidance. Here's a patient who had a right nipple discharge. You can see a ductogram was performed, and then there's a focally dilated duct with a duct cutoff sign. This was complete duct obstruction. And so this patient was biopsied under stereotactic guidance, and it was an intraductal papilloma. There is some movement towards MRI ductography. So this is similar to MRCP type technique for using heavily weighted T2 weighted sequences. It's non-invasive. Findings, you often see dilated ducts, tubular structures with high signal intensity. Lesions, again, would appear as a signal filling defect or wall regularity or even ductal obstruction. The limitations are similar to conventional ductography, that you're unable to differentiate between benign versus malignant disease or extent of disease. So advocates have kind of commented that if you're considering MR ductography, you really need to coincide it with contrast enhanced MRI. And so some of the papers that have been published related to that have shown some of the features related to it. So you can see here, dilated duct with a filling defect, and then a contrast enhanced MRI shows a lobulated mass, which is biopsied as a papilloma. Another patient here who had fused MRI images, again showing a dilated duct and an intraductal mass. Another question here. So a 55-year-old female with scaliness of the nipple demonstrates Paget's disease after skin punch biopsy. What is the next best step? So diagnostic mammography and ultrasound is step A. Step B is breast MRI. Step C is surgical referral, or step D is all of the above. Okay, so the most common answer was was D, all of the above, followed by B, breast MRI. So the next best step is all of the above. And so here we have a patient whose the MIP sequence of an MRI shows diffuse enhancement of the nipple areolar complex. And we reported this MRI as diffuse enhancement consistent with known Paget's disease, no evidence of underlying breast parenchymal abnormality. Now, when you look at the MRI a little bit closer, and in retrospect, you will see that there is some linear non-mass enhancement in the 6 o'clock position of the breast that wasn't really commented on. And unfortunately, this patient did present back 2 years later with invasive ductal carcinoma in that particular spot. So this really helps to illustrate the reason why MRI is so important in assessing these patients who have Paget's disease for underlying parenchymal abnormalities. So Paget's disease is adenocarcinoma of the epidermis of the nipple. Clinically, if you have very flaking scaliness or ulceration of the nipple, and then punch biopsy is usually performed. For mammography and ultrasound, the goal is to look for any underlying abnormality within the breast, and similar for MRI. And the important thing to probably take out of all of this is that 85 to 90% of patients with Paget's disease will have some sort of underlying malignancy, either most commonly DCIS, but some will even have invasive malignancy. So it's very important to try to find that if it exists. Okay, so another polling question. This patient presents with bloody nipple discharge. Please select the most appropriate diagnosis based on the imaging features. And I'll just leave it up here. So Paget's disease of the nipple, tubular adenoma, normal nipple, or D, nipple adenoma. Okay, so the majority of you selected D, which is nipple adenoma, and that would be correct. And so you can see here there's an axial, on the axial T2, there's a circumscribed hyperintense mass within the nipple itself, shows diffuse enhancement. And on a second look ultrasound, we performed this because this patient was relatively young. We had referred her to surgical consultation for biopsy this lesion, but she was young and she was really hesitant to undergo a nipple excision, and which is reasonable. So the surgeon asked us to do a very targeted second look ultrasound of that, just the nipple, to see if we can localize it a little bit more for her. And then so the surgeon did a focal punch biopsy of the area of concern and excised the nipple papilloma, and that patient remained asymptomatic. Here's another patient with similar imaging features of another nipple adenoma, stable for 3 years, no biopsy was performed. So these are benign lesions involving a major duct orifice in the nipple. Imaging is usually occult, and MRI is often demonstrating an avid enhancement. Differential is that of what we had discussed, Paget's disease or intraductal papilloma. Punch biopsy is the appropriate management tool, and then complete surgical excision is usually required because these can occur if they're incompletely excised. This is another patient who presented with bloody nipple discharge with a previous history of lumpectomy for invasive ductal carcinoma. I've pointed out the nipple here and then shown some additional linear non-mass enhancement in the retroareolar breast. Because of her history and some concerns clinically, she underwent MRI biopsy, which demonstrated benign ducts, fibrosis, and calcifications. And when you look back and compare it to her previous mammogram, you can see here that the overall appearance and nipple retraction was very similar. So we felt this was a concordant biopsy, which is pseudo-enhancement due to the nipple retraction. Closing off here shortly. So this last poll, I think it's the last one, but polling question here. So a 40-year-old asymptomatic female is undergoing screening ultrasound for dense breasts. This demonstrates an 8 millimeter intraductal mass. What is your next step? So the options are surgical referral, B, vacuum-assisted biopsy, C is to just ignore it and go back to routine screening, and then D is to do a short-term follow-up. Okay, the majority of you selected B, and then the next best one was D. So, you know, this is very controversial, but I'm going to throw it out there. So D is short-term follow-up. And as we do more and more screening ultrasounds for asymptomatic patients with dense breasts, we're going to see more and more of these retroareolar findings. And so this has been a topic of recent research, and just to see how do we appropriately manage these. Do we biopsy all of these retroareolar findings, or do we manage these a little bit differently? So you really want to correlate it with the patient's recent mammogram and their symptoms. And if the mammogram is negative and the patient is asymptomatic, then there are recent literature and studies showing that for these patients, the overall malignancy rate is very low, so close to about 1%. And so for carefully selected patients, imaging surveillance in lieu of biopsy may be appropriate in a patient with a negative mammogram. So just something to consider as we see more of a trend towards supplemental screening ultrasound. Here, I think we'll skip this as a polling question just in the interest of time, but I'll just read it through. So a 26-year-old female referred for surgical management of an irregular 1.7 centimeter biopsy-proven intraductal papilloma. What is the next best step? So an ultrasound here, you see an irregular hypoechoic mass. The borders are not circumscribed. This is certainly classified as a Barrett's 4C lesion. This was biopsied intraductal papilloma. So the next best step here would be either A or B, so surgical excision for possible discordance, or a vacuum-assisted ultrasound biopsy / excision. So this patient presented to us because the patient was reluctant to undergo surgical excision. So the surgeon came to us to see if we could try to excise it. So we used our vacuum assisted device and did a 10 gauge, using a 10 gauge device, did 8 cores, and the lesion was completely excised. This was a benign intraductal papilloma, symptoms resolved. And given the 10 gauge biopsy, we were very happy that we biopsied appropriately. And this has been kind of shown in the literature recently as well. And this study in 2017 in radiology concluded that there were low rates of upgrade or recurrence at vacuum-assisted removal, and a high rate of stability suggests that benign papillomas without atypia can be managed more conservatively. So in summary, we've really talked about varying management techniques for nipple discharge. Physiologic discharge should just go back to routine screening. Pathologic discharge really depends on the patient's age. And one caveat that we didn't really talk about, but something to note, any male patient presenting with nipple discharge really should undergo mammogram and ultrasound between the ages of 25 to 30. And it's because there's a high incidence of cancer in those types of patients. If these studies are normal, definitely go on to MRI or surgical referral for consideration of central duct excision. Otherwise, if they're abnormal, biopsy it under the imaging modality in which the abnormality was detected. Symptoms resolved, they go back to routine screening. And if they persist or are discordant, then go back to MRI. So thank you. I apologize for going over time, but thank you for your attention, and be happy to answer any questions. If I'm also happy to take any emails or any kind of correspondence afterwards. So thank you very much, and just hope you enjoy the rest of your conference.
Thank you. Thank you so much, Dr. Verma. It was a very crystal clear talk. There is one question in the chat box. How do you manage intraductal lesions in less than 40-year-old? Like the incidentally detected intraductal lesions, is it the same protocol that is followed for over 40 or under 40? Or do you do an ultrasound follow-up, or do you do a VAB excision?
Yeah, so that's a good question. It all comes up to like if they're symptomatic or not symptomatic. So if they're symptomatic, we will usually do a vacuum-assisted biopsy if they have features of clinically suspicious discharge. If they're not symptomatic, then the majority, we are seeing more of a trend towards imaging follow-up and surveillance. So we'll do a short-term follow-up, and we'll usually follow those patients for 2 years, and often we'll see that it was just some sort of intraductal debris that slowly resolves in those 2 years, and we can downgrade them.
Right, right. Thank you so much. Thank you for your time. It's almost midnight in Ottawa, and you're here for us. And also, thank you for doing this at a short notice. This is the weekend of the Canadian SBI, and Raman has been speaking at that conference too. And despite of that, he agreed to our request for change of date, and he's up here at midnight doing this talk for us. So we are truly grateful for that. This is the first time Raman is speaking to the audiences here in India, but I assure you, this is not the last time. You're on board, and if you would be so kind to be part of our teaching curriculum, a whole bunch of residents here would benefit from your knowledge, expertise, and experience.
Thank you, Dr. Ladd. I'm happy to be a part of this as much as I can. So I really appreciate the opportunity to speak here. And I had a chance to see many of the lectures yesterday, and they were excellent. So congratulations to everybody.
Thank you. Thank you.